We're honored to be joined by our speaker today, Dr. Matthew Koster. Dr. Koster is a Chicago native and a graduate of Loyola Stritch School of Medicine. He completed his internal medicine residency and chief residency at Loyola University Medical Center in Maywood, Illinois, followed by rheumatology fellowship and training at Mayo Clinic in Rochester, Minnesota. Dr. Koster is a staff consultant at Mayo Clinic with joint appointments in the Division of Rheumatology and the Gonda Vascular Center. He's a co-director of Vasculitis Clinic and associate practice chair for the Division of Rheumatology. Dr. Koster is passionate about helping accurately diagnose patients that suffer from complex vasculitis or aortic inflammatory conditions. The vasculitis group at Mayo Clinic is engaged in research at multiple levels, including epidemiology, translational research, and clinical trials in hopes of expanding our understanding of these rare conditions. We're deeply grateful to Dr. Koster for sharing his time and his expertise, and for all of you guys for being here today and showing up. And with that, I'm pleased to turn it over to Dr. Koster.
Well, thank you very much, Taya, for that introduction. And I want to thank Taya and her family for being instrumental in setting up the Retroperitoneal Fibrosis Foundation. And I'm honored to be a part of this first webinar, trying to give some additional information and insights into retroperitoneal fibrosis. So the main objectives for today are trying to provide some information in regards to retroperitoneal fibrosis and how it presents in many circumstances, as well as how to evaluate patients for this and what treatment to consideration, and also kind of how to follow patients over time, particularly from a monitoring perspective. And the hope is that at the end, we'll have some time for questions that we can address some of the things that are not covered in this particular presentation. And if we're not able to get to those questions during the Q&A, use them for the ability to generate new webinars in the future. So one of the things that I do want to start with is to discuss what is the retroperitoneum. So when we're talking about retroperitoneal fibrosis, it's important to understand what space we're actually describing. So when we're looking at this image, you can see here, if this is the front side, back side, right side, left side. What we're dealing with here is that the area of this light blue is actually called the peritoneal cavity. So that's largely the area in which your abdominal organs are in, the vast majority of those, as well as the most of the intestines. The area behind that tissue, so retro being behind, so behind the peritoneal cavity is called the retroperitoneum. Now that does include some parts of the intestines, including the ascending colon, so that's going to be coming from the lower part of the right abdomen up to the area by the liver. And then the descending colon, which is coming from that upper left side and then going down to the lower left pelvis. In addition, there's going to be the pancreas, the inferior vena cava, which is the main conduit from the venous structure, and then the aorta, which will be going, the abdominal aorta is largely what's in that retroperitoneum. And then, of course, the kidneys are going to be kind of a main feature that we're going to be reviewing. So essentially, all of these findings are within that retroperitoneal space. What do people mean when they're talking about fibrosis? So the challenge is that when a radiologist ends up using the word findings suggestive of or features consistent with retroperitoneal fibrosis, really what they're describing is a collection of soft tissue that they see on a CT scan. So when you're looking at a CT scan or other imaging studies such as an MRI, they're seeing soft tissue in an area, again, in that retroperitoneal space, that has different density in comparison to bone or like a solid organ. And so if they're seeing soft tissue collections in those areas, they end up saying a soft tissue density suggestive of retroperitoneal fibrosis. Now, the image of a CT scan or an MRI itself is not actually going to be able to tell you whether it's fibrotic or inflammatory. That's really what a biopsy would show. And also things like a PET scan, which we'll talk about later on in this presentation. But really, when we're talking about true kind of retroperitoneal fibrosis, idiopathic forms particularly, it kind of is on the spectrum of fibrosis and inflammation. So you can have some tissue that's been there, sometimes often for a long time. You may not know how long the tissue has been present for if you don't have a scan that didn't show it and then a scan that does show it. You can determine that it developed sometime in that interim. But for some folks, it's been there for several years and may have been dormant and not really symptomatic. And so those tissues tend to often have more fibrotic changes and not as much inflammation. Whereas kind of newly found or newly identified areas, they're very symptomatic, and often things in which they have high uptake on a PET scan will have a lot more inflammation than fibrosis, but people can exist along the spectrum. And when we're talking about fibrosis, really what we're talking about are these collagen fibers. So if you're looking at this biopsy, which was done from a patient with retroperitoneal fibrosis, these kind of pink bands of tissue are collagen fibers that are within the tissue structure that was sampled. That's what they mean by fibrosis. When we're thinking about the inflammation, then we're thinking about these kind of purple dots, which are really indicative of different white blood cells, often things like lymphocytes. And those are inflammatory cells that are embedded within the tissue. And so, again, dependent on how much pink collagen fibers, if that's the dominant feature, then that'd be more fibrotic. Whereas if it's very intensely filled with inflammatory cells, that'd be predominantly more inflammatory, and often these tissue structures fall somewhere in between. So if we're trying to understand the reason for the why of things like periaortitis or retroperitoneal fibrosis, really we don't have a great full understanding of why these things occur, but there's several thoughts or what we call hypotheses of why this may develop. So if we're looking at the area here represented by the aorta, right, so this entire thing is going to be the aorta, but the green portion is the outer lining of the aorta. The more tan colored is going to be the middle layer or the media. And then the orange or yellowish orange is going to be what's called the intima. The intima is the layer up against the kind of blood cells that are on the inside part of the aorta. So the intima, the media, and then the outer portion is called the adventitia. So the aorta is a big blood vessel, and since it's a big blood vessel, it actually needs tiny blood vessels to feed it nutrients, and that's what's called the vasa vasorum. That's this network of blood vessels that actually feed nutrients to the vessel wall. One hypothesis is that inflammation can actually occur because of localization of inflammatory cells that end up coming into the outer layer of the aorta through this vasa vasorum. For whatever reason, they localize and cause an inflammatory state, and then there's an emanation of that inflammation working its way outwards, causing periaortic inflammation, and also some changes inwards, like changes of these middle layers or increased atherosclerotic changes. One of the other hypotheses is that in patients who have more cholesterol plaque, and so we can see that having evidence of increased cholesterol plaque within the aorta is seen in patients who have a retroperitoneal fibrotic disease, that it may actually end up being that the inflammation is generated as a kind of reactive response to these lipids or cholesterol molecules, and that generates an inflammatory reaction that then ends up causing some inflammation that emanates out from the aorta. Again, we don't have a definition of what exactly does occur because of limited research within this space and incomplete evaluation from cellular pathologies in patients with retroperitoneal fibrosis. So Dr. Valio, who kind of proposed those two hypotheses in the slide before, has also been instrumental in the kind of words or terms that we use, or sometimes it's referred to as nomenclature. So if we're talking about an aorta that has some thickening in that outer layer, that adventitia, but it's not an aneurysm. So it's a normal size of the aorta, but it ends up causing some kind of tethering of that ureter either towards or within that fibrotic change. That is sometimes referred to as idiopathic retroperitoneal fibrosis. Now, we'll talk about why it's perhaps a better term to be used, but this is more commonly referred to these days as chronic periaortitis, because again, inflammation around that area of the aorta. If there is some inflammation around an already dilated abdominal aorta, again, typically below the kidneys, infrarenal abdominal aorta, that's often referred to as an inflammatory abdominal aortic aneurysm. So it's already dilated and it's inflamed. And then this kind of additional element where if there is some kind of tethering in of the ureters in an aneurysmal segment, that this is kind of this perianeurysmal retroperitoneal fibrosis. So these are kind of terms that have been described to try to generate an understanding of what is going on. But again, none of these have kind of withstood the test of time per se, because we're recognizing that there are other entities that can end up causing retroperitoneal fibrotic conditions. Not all of them involve the aorta. And so really when you're kind of looking at this, you have to understand that if you're saying you want to kind of define aortic inflammation or periaortic inflammation, perhaps chronic periaortitis would be a more appropriate description. So when we're comparing some of these terms like chronic periaortitis or idiopathic retroperitoneal fibrosis or just retroperitoneal fibrosis in general, the important thing is to remember that all inflammation around the aorta in the abdomen is going to be within the retroperitoneum, right? So all periaortic inflammatory disease in the abdomen involving the aorta within that space is going to be housed within the retroperitoneum by nature. That's just where it's located. However, not all periaortic inflammation is idiopathic. Idiopathic means we just don't know why. There's not another reason or a driver that we can identify as the cause. And truly, it's idiopathic, meaning we just can't tell or identify the reason. But what I will emphasize, and we'll show some test case examples, is that not all fibrotic disorders that occur in the retroperitoneum involve the aorta. So there are some areas where you can have soft tissue collection in certain parts of the retroperitoneum, but they're not actually involving the aorta. And those are ones in which we have a higher suspicion or concern that a different disease is actually driving the process and needs to be evaluated further, and not just labeled idiopathic. So when we're talking about primary versus secondary conditions, so primary is really like the idiopathic forms, meaning like we don't know why, and that's just the condition that it is. Whereas secondary is going to be things in which there's some other reason why this is developing. Now, listed here are several options for things that must be considered by someone who's evaluating someone for a question of retroperitoneal fibrosis, and ideally considering these entities before the label idiopathic is placed upon a patient's case. Some of these medications are kind of older used medications like the methylsergide and bromocriptine, which are often used for things like migraine headaches. Hydralazine and beta blockers, however, are very common medications, typically used for blood pressure control or rhythm control in cardiology. And so while there's been some suggestion that there may be a linkage, causation, meaning that it's directly caused by these medications, has not been fully established. We do know, however, that certain cancers can cause soft tissue collections within the retroperitoneal space, particularly lymphoma, breast cancer, colon cancer, etc. And so again, these things are important because if there's soft tissue collections that we feel are not classical for chronic periaortitis, then trying to identify whether a biopsy can be obtained to see if there is some malignant tissue that's driving this etiology is critical to diagnose what's going on for these patients so that they can get the appropriate therapies. In addition, patients who have had radiation to the abdominal pelvic area can develop very soon after the radiation or many years after the radiation, a development of a fibrotic process that may end up causing this reactive change. Now, often it tends to be more fibrotic than inflammatory, and so often when you biopsy, highly fibrotic, not much inflammatory cells, and in these patients, steroids are of limited benefit. Surgeries can be seen as a precipitant. Now, it's hard to tie exactly a cause because sometimes a lot of people have had abdominal surgeries of different reasons because these are common surgeries, like having a removal of a gallbladder or an appendix, for instance. It tends to be ones who've had recurrent abdominal surgeries or patients in which they had some complication, whether it was a bleeding complication or an infection complication that made it more challenging for that surgery to occur and may have had some kind of reactive process that occurred in response to that trauma within the abdomen. Other conditions, which we won't go into in too much detail, but a condition called Erdheim-Chester disease is a known condition that involves these cells called macrophages or histiocytes that can infiltrate into soft tissue. And those can end up causing retroperitoneal soft tissue thickening, particularly around the aorta, but will often have other features within the abdominal pelvic region involved as well, and even outside of that space throughout other parts of the body. Abdominal trauma, as mentioned, either through surgery or other, can be an issue. Certain infections should be evaluated and screened for. And from autoimmune conditions, ANCA vasculitis has been reported to have some periaortic inflammation. And then also IgG4-related disease. Part of the difficulty with again, nomenclature is kind of the classification of things based on words. In some groups, people will refer to as idiopathic retroperitoneal fibrosis with IgG4 lumped in. Now, IgG4 is a separate entity, and so it's important to, in this context, differentiate between IgG4-related disease and idiopathic forms because there are more defined treatments for IgG4-related disease. So if that is present, then certain medication regimens may be more ideal in that situation compared to the idiopathic forms. So why don't we know a whole lot about idiopathic retroperitoneal fibrosis? And part of it is it's an uncommon condition. So there's not very many population-based studies that have evaluated this condition. We had done one, including what's called the Rochester Epidemiology Project, looking at Olmsted County and its surrounding areas. And we found that the frequency was approximately 1 in 150,000 patients. Now, in order for it to be truly considered rare or an orphan disease, it needs to be less than 1 in 250,000. If you're looking at the frequency, it is higher in men. So in our group, we saw 1 in 65,000 men per year annual diagnosis versus 1 in 350,000 women. The other difficulty of why this is not well understood is that it's not very much focused on in medical school. It's not one of the areas in which there's a lot of information or training within the pathology section or the radiology section or within surgery or medication or medical rotations. And also, it's hard to know as far as kind of these circumstances where it should be housed in regards to who should teach about it. And we'll talk about some of those difficulties about which specialty should be kind of the anchor or the quarterback for this. And really, that's part of the challenge is that it's really something in which the exact entity is not certain who should manage it. In our institution, it's rheumatology, but in some other areas, it might be nephrology or other medical providers. So one of the things that I do empathize with for patients who have retroperitoneal fibrosis is they seem like they've had some difficulties with finding a provider in many circumstances. They may go to one person and they're like, well, that's not really me. Or they go to another person and they say, also not me. So they're trying to find a provider who knows about the condition, who feels comfortable with the condition and can manage it and kind of coordinate their care. So you may have heard similar things like this, right? So if there's issues of an abnormal kidney function and they find that the urine's not getting out and it's because of some obstructive process from periaortic inflammation, then a urologist may be one of the very first people that this patient sees, and they put in the stents and it reestablishes flow, but then they're more of a surgical practice, and so evaluating it from a medical stance is not kind of their area of expertise or their focus. And so they say, you know, I've put in the stents, you need to have someone else assist you with this. Now, if there was abnormalities within the kidneys, then sometimes what happens is they'll end up going to a kidney doctor. But often the challenge is that it's not a primary kidney disease. The reason that there's a problem is there was obstruction. And ideally, if the obstruction is dealt with, then the kidney disease may not progress as substantially or it may improve or resolve. And so since it's not a primary kidney disease, a nephrologist may not be the person who feels most comfortable with managing it. And then often with these masses, there's a concern initially of, is this cancer? And so people may go to a hematology or oncology physician and they may attempt to biopsy the tissue because lymphoma and other cancers are on that list of differential, as we mentioned. But the difficulty is that if the biopsy comes back and it's not cancer, you're not going to receive chemotherapy for it from a cancer physician. So they end up saying it's not cancer, perhaps it's not me. And then kind of other providers, whether it's rheumatologists who are not comfortable or familiar with this condition or primary care providers, if they feel like they've never seen it, then they don't feel like this is a space that they are best suited to assist you and manage you through this. So what I do want to provide some context is in evaluating patients at our institution, we ended up reviewing cases with new diagnosis of idiopathic retroperitoneal fibrosis. So they had to have exclusion of those secondary causes. And we identified patients with new diagnosis between 1996 and 2019 and identified 314 of those patients. So some of the demographics are shown here. So you have on average, the diagnosis age was about 56 years, plus or minus 10 years on each side if you're going based on the averages. Most were men, almost 2/3, and the majority were white, about 80%. Now, there are reports of patients who end up having retroperitoneal fibrosis in non-white populations. We have a little bit of a predilection for that based on the area where we're at in the upper Midwest, but we do get referrals from the rest of the country and also from international referral groups as well. About a third of them, a little bit over that, had a history of abdominal surgery, but these surgeries were often about 6, 7 years from the identification. So kind of hard to pin it on specifically that abdominal or pelvic surgery. But of interest, a large proportion of them were either current or former smokers. So here we have approximately 73%, almost 3/4 of patients had tobacco use exposure previously or currently. And we do know that smoking does seem to be a risk factor of developing these fibrotic conditions. Most of the patients had some symptom when they were presenting and being found to have idiopathic retroperitoneal fibrosis. Very few patients just had this found on a scan and they had absolutely no symptoms whatsoever, but that did occur in a few rare circumstances. Unfortunately, the symptoms tend to be pretty non-specific. So often it'll be just abdominal pain or back pain, or sometimes pain on the side, like flank pain, which is often kind of over to the side or just below kind of the back portion of the ribs. These are the more common features, but are not often localizing to a specific reason. And so sometimes these patients were just monitored without intervening or monitored without evaluating with additional imaging until it got more symptomatic, or they went to something like an emergency room and had a scan for progressive symptoms. Leg swelling can occur in about 1 in 6 patients, and we'll talk about some of the characteristics of that and how to evaluate for venous obstruction, and then some other less frequent nonspecific symptoms like vomiting, night sweats, and fever. Of note, the range of the creatinine was quite wide, so it went from completely normal to very bad. Some patients on dialysis at that point. Inflammatory markers were elevated in only about half of the patients. So, checking labs like inflammatory markers can be helpful if they're very high and people start investigating for the why the inflammation markers are increased, but they're not universally elevated in all patients. Kidney dysfunction is an important element of this, and we'll talk about the importance of focusing on that quickly and trying to intervene rapidly to preserve kidney function. But approximately half of patients had already some element of kidney disease at stage 3 or worse. And again, about 1 in 8 patients ended up having some element of either being in the worst stage, stage 5, or requiring dialysis at the time of diagnosis. 46% of patients ended up having dilation of the urine back up and what we call hydronephrosis, which will show some images in a few slides. And it was about split between how many had just one side or had both sides. And often, if it's just one side, it tends to end up being a little bit more on the left side, the left kidney being backed up compared to the right, just because of issues in which the ureter tracks a little bit closer to the aorta on the left side anatomically. Kidney atrophy is a feature of kind of longer standing malfunction of the kidney and an indication that there may not be recovery of that function. And so that was seen in 15% of patients. Again, rarely would that be on both sides, often more on one and traditionally more on the left side than the right. Stents were needed in 49% of patients, 19% on one side, 30% on both sides, and nephrostomy tubes were needed less frequently. And part of that is that ureteral stents are often used as the first line management in nephrostomy tubes only if there's been a lack of assistance from the ureteral stents themselves. When patients are identified or being evaluated for periaortitis or retroperitoneal fibrosis, there's a lot of different scans to consider as far as what things can be used to evaluate. So CT scan is often one of the very first ones that's done. They're often quick, easily obtainable. Many areas have them, urgent care, emergency rooms, outpatient facilities. They're fast, but they do have radiation, and sometimes dependent on the kidney function, contrast is used to help delineate the aorta from the surrounding soft tissue. They're very good at anatomic detail. So if we're talking about kind of description of how thick the area around the aorta is and how much it's improved, they are able to do that with very good resolution for comparison. MRI, perhaps a little bit less spatial resolution than CT scan. The benefit is no radiation, but it's the tube, right? So some people have issues with claustrophobia or anxiety being within the tube as opposed to the CT scan, which is more of kind of like an open ring or a donut, as sometimes people call. And part of the challenge as well is the scan takes longer, about 2 to 4 times longer than a CT scan. And not all people can have it because some people will have implanted devices like a pacemaker or a spinal or bladder stimulator or something of that nature. And depending on how old and its compatibility, it may not be able to actually undergo an MRI. PET scans are good, and we'll show kind of the reasons why and how they can be assistive in determining inflammation more than anatomic detail. But the CT scan portion is not as assistive because it doesn't have as good clarity and also doesn't have the contrast to compare to the outer structures. The biggest downside is that they're expensive. On average, these are about $8,000 to $12,000, whereas a CT scan can range between like $2,000 to $4,000, MRI maybe $3,000 to $5,000. And often PET scans may be declined by insurance because they're most frequently used in the context of malignancy evaluations, for which this is not technically an evaluation for a malignancy. And so sometimes insurance companies may not allow approval or not provide reimbursement if it's been done. A nuclear medicine Lasix renogram. One of the benefits for this is what it does is it looks at split function. So ideally, your kidneys are working 50-50, right? Kind of sharing the support, or even 55-45, or maybe 40-60. But if there's an obstruction, then one side's going to have to compensate more than the other. So it's really trying to evaluate how much each kidney is contributing, and that can help provide some context of is there obstruction and how much that might be impacting the function of the kidney. So those are helpful, particularly if you're trying to determine if there's already some kidney atrophy. Is it worthwhile to try to put a stent in? Because if there's very little function on that side, you might not recover a large amount by keeping the stent in if it's already in place or putting a stent in if it hasn't been put in yet. Kidney ultrasounds are available, easy to obtain, no radiation. The problem is that it's really just looking for the backup of the urine, so the hydronephrosis. So if that's one of the symptoms that had caused pain previously and you're wanting to make sure that the stent is working okay or the stent's been removed and you want to see if there is backup of the urine after it's been removed, kidney ultrasound is pretty helpful, but it tells you nothing about the soft tissue mass. You're not going to be able to see is that improving over time or with therapies. So if we're looking at kind of scans like this, so this is a CT scan. And so if we're looking, this is the front side of the abdomen, back side, right side, left side. And we're looking in this axial plane, meaning that we're kind of cutting through the body and almost looking at it like a slice of bread. So here in blue is the big vein, the inferior vena cava. And then the red is going to be the aorta. And then the green outlined here is all that extra soft tissue. Now, again, when we're talking about these features, you can see that this kind of gray, this darker gray, is different than the white of the kidney and the white of the bone, right? So different densities. And so it kind of has similar color to kind of these soft tissues. These are the paraspinal muscles. So this is why they're saying like soft tissue thickening, or they would end up saying kind of features of retroperitoneal fibrosis. But the scan, again, cannot tell you, is this fibrotic or is it inflammatory? A CT would not be able to determine that definitively, but just raise the question of the causes of why that tissue may be there. So here is that same patient after they had undergone treatment. So you can see here, this is that vein. Again, it's actually opened up nicely, increased in its size since there's less fibrotic tissue or less soft tissue that's around that area. Here's the aorta, and then there's that smaller area of the soft tissue thickening around the aorta that's decreased in comparison over time. So CT scans are good to see kind of changes, and in here you can see that it's improved, but it hasn't fully resolved. Now, when we're talking about what is the distribution of the area of abnormalities, so if we're looking here, this blue is the inferior vena cava, vein to the kidneys, aorta, artery to the kidneys. The area of typical involvement is what we call the infrarenal abdominal aorta, so the area below the kidney arteries. And then it can continue in some circumstances until the aorta splits into the common iliac arteries, and then it'll end up stopping before it gets further down into the pelvis or to the legs. And so here's an example of what we're seeing for that. So we have this cross section where we're going into the abdomen and we're seeing the structures here is the liver, stomach, spleen. Here's the aorta. And then as we move down, we're getting to the level of the kidneys. And now you can start seeing the soft tissue develop around the aorta. Again, more anterior lateral, not as much posterior. And then as you keep going, you can see that area still thick. And then getting to the spot where the aorta splits, that bifurcation. And then kind of soft tissue ends up resolving after that, not being seen. These white spots are actually calcium plaque, so atherosclerotic changes that have been there more consistently. So when you're seeing a patient who has retroperitoneal fibrosis, the most important thing is to deal with the kidney function. So if there's evidence of obstruction of the urine, what you want to do is alleviate that obstruction, and that may end up needing to be through either nephrostomy tubes or more commonly ureteral stents. And so we'll show kind of what that ultimately looks like. But stent placement, typically first line, nephrostomy tube if there's a failure of those stents or if there's some reason why it just can't be completed. The next step is trying to make sure that there's not venous obstruction. And the reason for venous obstruction being important is that sometimes patients, if they're not identified, they can have massive swelling of the legs or also develop blood clots within the iliac veins or even the inferior vena cava, which can be significantly problematic. Simultaneously, while all this is going on, really what you want to do is try to identify what is the cause. And so working through that list of kind of the secondary processes and then trying to identify whether or not you can find something on that list that would modify your approach, right? As opposed to if nothing on that list is identified, then more likely it would be an idiopathic. So when we're talking about hydronephrosis is really this backup of the urine, right? And so when we're talking about backup of the urine, it's because it's not getting from the kidney down to the bladder, and so it's kind of hanging up in this area. Hydroureter is a little just a bit further down, in which you end up seeing that the ureter here, in comparison on the left side, is small compared to the backup on the right side. And we're seeing this because, again, you're just not able to get stuff all the way from the kidney down to the bladder. There's some level of obstruction. And so similarly to before, we'll end up using kind of a video here to demonstrate that. And so if we're seeing at this portion, you're going to end up seeing here some dilation of that urine up in the kidney, what's called the renal pelvis. So that's kind of that area of that hydronephrosis. And then as you continue, you can see this hydroureter. And then as you move further down, you can see ultimately that that ureter is coming right by that fibrotic tissue and mass. And that's really where that obstruction happens. and it's the backup that ends up creating that hydronephrosis in the hydroureter. This is conceptually what that causes, right? So if there's backup, what happens is with time and chronicity, you're going to end up losing the function of the filter of the kidney because the nephron is kind of the unit that filters the urine and produces it. And so if you're not allowing urine to get out and then down to the bladder, it's just backed up there. So it's kind of like if there's an assembly line and you're producing a bunch of supplies or whatnot, and it's getting to the end of the assembly line, it's just piling up. At some point, you're going to end up saying, gosh, maybe we should just stop making the things because there's plenty of them at the end of the assembly line. It doesn't seem like it's going anywhere. And so then you kind of just shut down the assembly line. And so that's ultimately what will happen with chronicity of the obstruction, is that you will end up losing the productive capacity of the kidney, which may be irreversible. So what we're seeing here is that if you have an obstruction to a kidney, with time, it will atrophy, shrink, lose its function. And so here's a kidney that did not have obstruction and a kidney that did have obstruction. And the area of the obstruction for this is the soft tissue around the aorta a little bit further down, which is just why you're not seeing it within this specific area. This is just a different view, kind of looking face on. And so this is the unobstructed kidney and the obstructed atrophic kidney. So really, if there is backup, you want to alleviate that backup so that it's not persistent and causing irreversible dysfunction. One of the ways to reduce that backup, again, is by putting in ureteral stents. So someone would have a ureteroscope or a cystoscope that would go in through the bladder. They would end up putting a guide wire up into the kidney. They would then end up putting in the stent and then making sure that the contrast comes down nicely from the kidney down to the bladder. And so that's kind of the pictorial representation. Here's an x-ray showing kind of the territory, the length. People often wonder, how long are these things? They're essentially going from just below your ribs all the way down to your pubic bone. And that's because they have to go through that whole space between the kidney down to the bladder. So here's a video showing kind of what things look like when they're putting in these. So here you have kind of the coiled ureter stent, and then you have the contrast that they're administering through a guide wire to make sure that that contrast ends up nicely coming down from the kidney into the bladder on both sides before they end up pulling the guide wire out and leaving the stent in. And so again, from this context, just looking at it in a different view, you're going to end up seeing here the ureteral stents are coiled up within that part of the kidney, and then you're going to see that they end up coming down, and you'll actually end up seeing that they end up approaching right into that fibrotic tissue. And it's through that fibrotic tissue, again, that they end up getting clamped down. But since now you have this plastic stent that's within that space, it keeps it open, ideally, and allows for the urine to go down. One of those most common questions that we have when people have stents placed is, am I going to have these forever? And the answer is not necessarily. Part of it is how you respond to treatment, if treatment's initiated and shrinking the mass that's obstructing the ureter, or if surgeries like a ureterolysis, which actually moves the ureter away from the fibrotic tissue, if that's performed. And so again, in that 314 patients, of the patients who needed, about half of them needed stents, almost 2/3 of them had them out and remained out by kind of the 3-year follow-up mark on average. What's important, however, is that if stents are placed, you do need to follow with a urologist because they will have to exchange these periodically. Plastic stents are often every 3 months. Sometimes they can extend them a little bit further beyond that if there's kind of ongoing frequency of need. And then there are some longer stents that can be placed, not longer in length, but longer in duration. And metallic stents are able to be in for a longer amount of time, often 6 to 12 months. So what about nephrostomy tubes? So nephrostomy tubes, instead of going from the bladder to the kidney inside, it's actually going from the outside into the kidney. And so you end up having, again, a needle that goes into the kidney, a guide wire that's put over there. Then they kind of put this kind of plastic tube over that guide wire, and then they end up leaving that tube in the kidney, and then it'll actually go out through the back and be attached to a bag. And then you would empty the urine from the bag. And so this is kind of a picture of those tubes within the kidney. And again, they're putting this contrast in to make sure that it's going into that kidney pelvis appropriately and then draining out through the bag. Nephrostomy tubes, some people don't like them because, again, then you have kind of your urine on the outside. But if the ureteral stents are not feasible or not functioning, this is an alternative way to allow for people to continue to have ongoing urine production and getting the urine out appropriately without backing up or causing kidney failure. Again, the kidneys are the most important thing, but kind of the second most important thing would be venous obstruction. And so if we're dealing with venous obstruction, you may have patients who say, you know what, I have huge amount of swelling in my legs. And people said you could have a DVT, or deep vein thrombosis, a blood clot in the deeper veins within the legs. But then they had an ultrasound and they actually didn't see evidence of blood clot within that area. Well, the important part is that this is the territory that people would be evaluating if they're looking for a deep vein thrombosis. But really, the obstruction in patients who end up having retroperitoneal fibrosis is further up than that. Again, typically within the inferior vena cava or in these kind of more proximal iliac veins, like the common iliac veins. And so if you do an ultrasound down in the legs, you're not going to see that. So often you'll have to either do a higher up study in ultrasound, looking at kind of the inferior vena cava or the iliac veins, which is a separate test that is not always ordered in combination with this lower extremity ultrasound study, or what's called a CT venogram, which is looking at kind of the veins more than the arteries. And so here's a patient in which they had significant lower extremity swelling. It was both sides, but it was more on this, again, right side of the screen, but left side of their body than the left side of the screen, which is the right side of their body. So you can see that the contrast is being placed in there, and really not much is going up the inferior vena cava, not much is going down into the iliac vein. So what had to be done is they had to go in and do a procedure, an interventional radiology procedure, where they actually put guide wires up both iliac veins into the inferior vena cava, and they end up putting kind of these crossing stents that kind of end up going through each vein up into the IVC. So this is just looking at after that placement to kind of show you what they look like. And so you'll end up seeing these kind of bright white areas, right? That's one stent. That's the other stent. And so that's kind of coming up each iliac vein into that inferior vena cava to allow for kind of ongoing flow back of the venous structures up from the legs back to the heart. So when we're trying to understand the diagnosis of patients with retroperitoneal fibrosis or periaortitis, the main thing is that really you need to have a good detailed history and go through a lot of the information. And so as a patient, it's important to have some knowledge about when did the symptoms occur, how have they been progressing through time, or treatment started, how did you respond, and then also knowing your other medical history, right? So is there a personal history of cancer or a familial history of cancer? Did you have abdominal pelvic surgeries? If so, when? Have you ever had radiation? If so, what parts of the body or kind of what fields were exposed to radiation? And then kind of family history of other things like autoimmune conditions are also helpful and important. Really, you have to have a detailed, comprehensive physical examination because of the types of conditions that are listed on those secondary causes. And it should really include evaluation of lymph nodes, armpits, groin, so kind of what we call axillary lymph nodes, and then kind of the inguinal lymph nodes, which is around the pant line or belt line. And then also kind of head and neck lymph nodes and glands, and then around the eyes, the lacrimal glands. Again, trying to evaluate for things that may increase suspicion for conditions like IgG4 related disease or things like malignancies or lymphoma specifically. Lab evaluations with blood counts, metabolic profiles, urine studies, inflammatory markers like sedimentation rate, C-reactive protein are all key for this. And then consideration in certain populations or certain presentations for evaluating for things like ANCA vasculitis and IgG4 related disease. Ideally, IgG4 should be checked before steroids because steroids can reduce that value. And if you're on a lot of steroids and then someone checks it, you actually don't know if it was elevated beforehand. Now, the frequency of histoplasmosis and tuberculosis causing periaortic disease is actually pretty low, but it's important to evaluate and exclude because immunosuppressive medications could actually make things worse. And we'll talk about in these upcoming slides how PET scans can be used and how they're important, and also biopsy and who and how to end up proceeding with that. So one of the main things is that if you're looking at scans, there are some certain characteristics and patterns of where the soft tissue is at that would help you identify, is this more of a classical idiopathic chronic periaortitis, or is this something that could be due to a different disease entity and therefore you need to pursue further with identification of that disease? So one of the things in our institutions, we find that some people have never had a biopsy, or they had a biopsy and it was difficult to obtain, or scant amount of tissue and it wasn't repeated, or it said that there was no cancer and people were happy with that, even though maybe there are visual evidences of abnormalities that need to be further pursued. So are biopsies safe, and how much thickening needs to be present for there to actually have tissue retrieved by a needle, like a CT guided biopsy? So we looked at, in again, our group, 83 patients with 84 biopsies, and the lower level of thickness, which was not seen in everybody. The average thickness was around 14 millimeters, but ranged between 3.5 to almost 28. But think about it, 3.5 millimeters is about 2 quarters stacked on top of each other, right? Whereas 14 would be 6 quarters stacked on top of each other, and then 28 would be 14 stacked on top of each other. So again, kind of this is kind of the amount of thickening that you're seeing. It's not a lot of thickening, and it's around one of the major vessels. So really you have to have someone who feels comfortable and confident that they could be able to get that. But really these were well tolerated. Very small amounts of bleeding and typically negligible. Only one person had a little bit more of kind of a collection of blood within one of the muscles of the abdominal wall that needed kind of any intervention at all. Nobody had any evidence of infectious complications. And the important thing is that only a few patients ended up not having enough tissue for the pathologist to evaluate adequately. So most of these patients, over 90%, ended up having tissue that they felt was adequate for the evaluation. So when we're talking about who should get a biopsy, really it's one of these things in which there's kind of abnormal findings or features. So if the radiologist, or if you're seeing some features of infiltration or destruction of kind of surrounding kind of abdominal pelvic contents by the soft tissue, that would be atypical. That's not normal. So more kind of traditional chronic periaortitis or idiopathic retroperitoneal fibrosis kind of respects the boundaries and planes and doesn't infiltrate and destroy. In addition, again, kind of the more common findings around the infrarenal abdominal aorta. Now, sometimes you can have that plus something else, but if you're having either in isolation or kind of dominance in kind of the lower pelvis or the sidewall of the pelvis, or around an abdominal structure like the colon or the duodenum or the pancreas, those are suspicious for another cause and need to be further evaluated. A lot of bulky lymph nodes are important because sometimes lymphoma is on the differential, and we'll talk about this perinephric thickening, which, if present, increases the suspicion for the possibility of things like histiocytic disorders like Erdheim-Chester disease. If someone has a known history of cancer, I think that they deserve a biopsy, because sometimes we can have it where patients end up having the cancer, and it may not even be where it was initially, but this is identified as a metastatic spread. And so also, if none of these are present and they're started on treatment because you didn't find a secondary cause, and it's presumed to be something in which someone has kind of these kind of idiopathic forms as a presumption, and they're started on treatment and they have absolutely no response, or it goes in the wrong direction and worsens, those patients certainly should be considered for biopsy as well. So here are some examples in which it's helpful to end up doing biopsies for patients. So this is someone who had some pretty significant aortic thickening in the chest. So this by nature is not the retroperitoneum, it's intrathoracic because there's no peritoneum or retroperitoneum in the chest. So that's already outside of that territory, which makes you think it's not idiopathic retroperitoneal fibrosis. And then that thickening extended pretty significantly through the entire aorta, and had this area of perinephric thickening, or this rind around the kidneys, which is not traditionally seen in retroperitoneal fibrosis. And so this person had a biopsy of that tissue, and it confirmed a condition called Erdheim-Chester disease. Here's someone who had more dominant features of soft tissue thickening lower down in the pelvis, away from the iliac arteries and the aorta. And part of the benefit of a PET scan is that it can show a lot of other territories of involvement. So here's kind of those definitive features of lymph nodes, and also some abnormal bone marrow signal. And so when a biopsy was done of both the bone marrow and the lymph nodes, it confirmed features of involvement with a condition called follicular lymphoma. Now, this is someone who did have a little bit of soft tissue thickening around the aorta, but they also had some thickening around the area by the duodenum, kind of that first part of the small intestine. And they had tried to have ureteral stents, but they weren't working, and so they had to have nephrostomy tubes placed, which, again, the vast majority of patients are able to be managed with ureteral stents, and failure of that is uncommon. So they had a history of breast cancer, and the PET scan did not show any features of uptake of soft tissue within kind of that territory of the breast tissue, and their oncologist felt that they had been in clinical remission from breast cancer. But nevertheless, an aggressive approach to do endoscopic guided biopsies, so meaning a scope going down through the stomach into that small intestine and then biopsying through that small intestine was able to get tissue from here, and it did confirm evidence of metastatic breast cancer. And then here's someone who had ureteral obstruction with some abnormalities that kind of layered into these paraspinal muscles and were listed as being kind of infiltrative and very high uptake on the PET scan. And this person actually had 3 CT-guided biopsies, all of which were non-diagnostic and had been presumed to be idiopathic. But given these features, we had not felt comfortable that that was the case. And so it actually required open surgery with a combined approach with general surgery, orthopedic spine, and ortho-oncology. And ultimately, they were able to find that this was an infection within the spinal hardware. And then as we've looked at some of the CT scans, you can see how this is very intensely bright. So kind of the upper limit of normal, you can see a little bit of the liver here is kind of this greenish blue. Kidneys filter the tracers, so they're always going to be bright, but things that are solid green, orange, yellow, red are increase of that tracer within the PET scan, meaning kind of uptake of the tracer means inflammation or at least cellular activity, metabolic activity. So this almost looks like a jelly donut, right? So very thick and also kind of circumferential with a lot of thickening behind that aorta. This person had other spots though too. So this is actually up in the chest in the area within kind of the right lung, right around the airways. And so ultimately biopsy from this tissue and this tissue ended up confirming IgG4 deposition at high levels consistent with IgG4-related disease. Now, PET scans are helpful to identify where tissue may be abnormal and where to target, but can also be quite helpful when you're evaluating response to therapy. So that same patient from the previous slide, we have their kind of tissue abnormalities prior to treatment, and then they had received rituximab for management for IgG4-related disease. And you can see complete metabolic resolution after treatment, showing significant response to therapy. So when we're talking about who should be the people who assist in the management of retroperitoneal fibrosis, in most institutions, at least in ours specifically, the rheumatologist tends to be more of the quarterback of this because often prednisone will be needed and or other immunosuppressive therapies, which other service lines listed here would not be comfortable with. A urologist is important if there's obstruction, if there needs to be stenting or stent exchanges, or if at some point in time there's a consideration for surgery to move the ureters called ureterolysis. Vascular interventional radiology are helpful to establish if there's venous obstruction and management, again, with sometimes stent placements within the iliac veins or the inferior vena cava. Nephrology, as mentioned, it's not a primary kidney disease, but trying to reduce the consequences of chronic kidney disease are helpful. So medication monitoring, blood pressure control, those types of things are going to be important because that's not really in the purview per se of rheumatology to monitor and provide commentary on how to optimize. And then internal medicine. So these patients, if they are on steroids, they could have rises in their glucose values or their blood pressure values, and kind of vaccines may be required and management of things like osteopenia or osteoporosis. So really needs to be some type of coordinated approach to best assist and manage people with these conditions. Now, a lot of the information on this slide, I'm not providing a lot of kind of the background data because it's a little bit too much to delve into in this particular talk. But listed here are some therapies that are known to be effective in the context of certain entities that are driving periaortitis if present. So IgG4-related disease, rituximab has historically been used, but Uplizna and evolizumab has now been recently FDA approved for the management of IgG4-related disease. For patients with ANCA vasculitis, rituximab is FDA approved for the management of that condition. Erdheim-Chester disease actually has 2 therapies that are FDA approved, dependent on the mutations that are seen. These are often these BRAF mutations versus other mutations found within the tissue if they do genetic testing to look for mutational markers. If you have cancer, lymphoma, breast cancer, pancreatic cancer, etc., it's really treating the cancer. Right now, you may or may not improve that periodic soft tissue thickening with the management of the malignancy, but treating the malignancy is the most important element, and then just dealing with the ramifications of what have occurred from that kind of driver of the tissue within that retroperitoneal space. For radiation, unfortunately, there's really not much known for benefit. Steroids have been tried, really not as much directly impactful on that. Most of it's because it's often more fibrotic as opposed to inflammatory, so not expected to improve dramatically. So these next few slides will be focused more within kind of the management of patients with idiopathic retroperitoneal fibrosis or chronic periaortitis. And so these are ones that have been evaluated and ideally excluded for those other secondary conditions which may have different therapies. Now you'll see that there are some overlapping ones here, like for instance, rituximab can be used in some circumstances, but often it's prednisone up front and then the use of a different steroid-sparing agent is what we would call them. So mycophenolate, also called Cellcept, methotrexate, also called Trexol, tocilizumab, trade name is Actemra, and then rituximab, trade name is Rituxan, right? And there are several different biosimilars for these, meaning kind of agents that have similar function but lower cost. Tamoxifen, people may have heard of, that's been used historically, but not as favored as much presently. Largely, that was initially started because of thoughts that it could help in other kind of fibrotic or fibroinflammatory conditions like desmoid tumors. One of the very few studies that actually has been done where there's been randomization of patients to determine whether a therapy was given or not and assessing the outcomes was actually done by Dr. Augusto Valio, who was mentioned earlier in this talk. And they looked at maintenance therapy with either prednisone or tamoxifen, and actually prednisone ended up winning out over tamoxifen, which has kind of led to its less frequent use more recently. Often patients, when they're diagnosed with retroperitoneal fibrosis, they'll end up asking, like, what does this mean for me over the next several years? And so trying to provide kind of a prognostication of if things all move in the right direction, what are we thinking about here? So the first stage is trying to obtain the diagnosis and the cause, right? So find out if it's really idiopathic as opposed to a secondary cause. Ideally, a PET scan baseline and ideally before steroids, if possible, is important to say if it's more intensely uptake metabolic changes within the soft tissue, the higher likelihood that you'll make some impact with steroids and immunosuppressive therapy. If it's more fibrotic, that outcome will be potentially limited. And then again, treating kind of the obstructions, whether it's venous or renal in nature. That's right away. Once the identification of things have been done, then really it's often initiating steroids to assess kind of quick initial response. I don't always end up starting immunosuppressive therapy simultaneously with prednisone immediately because part of it is to say you want to assess how things are responding in a short term to say, are you going to actually move forward and have some improvement, right? So if you have a PET scan that's very quiet and you give steroids and there's no change, there's likely going to be little benefit if you give a lot of immunosuppression for several years and it may be unnecessary and you might just incur the risk without the benefit. So in this context, often we start with a high amount of steroids, tapering down, repeating the scans about 6 to 8 weeks and assess kind of the impact and the outcome. So kind of going from month 0 to month 2. And then kind of at that next stage, adding in steroid-sparing agent, whether that be Cellcept or methotrexate. But largely that's done based on how there's response, like I said. So if there's resolution or improvement, but not resolution, that's moving in the right direction. If there's been no change or worsening, then that may kind of give you pause to either reassess additional biopsies or other studies if it's worse, or if it's been no change, then determine do you actually want to taper off steroids quickly and to reassess with imaging before you do immunosuppressive meds chronically. But if steroid-sparing agents are started, traditionally I will then bring the patient back approximately 3 months later when they're around 20 milligrams of prednisone, coming down from that dose that they were at that 6 to 8 week mark. Then kind of moving forward, kind of reducing the steroids with time, continuing on the disease-modifying agent or steroid-sparing therapy, and then repeating images kind of around 10 milligrams of prednisone, and then getting off of prednisone. So looking at that, that's about a year of prednisone therapy going from kind of 60, 80 down to 0. And then at around kind of month 18 or so, then that's trying to evaluate for patients off of therapy, right? So kind of on the steroid sparing agent, but off of prednisone, I should say. That's trying to assess with these lower values, 10, 0, and off, whether that steroid sparing agent is actually beneficial and helpful and actually helping more so than just the prednisone was. So if you saw benefit early on with both, and you continue to see benefit as the steroids are tapered and off, then that's showing that the steroid-sparing agent is helpful. If you saw prednisone benefit early on, and as you're coming down on the prednisone, despite being on that additional med, things are moving in the wrong direction, then that means the higher doses of steroids were helpful, but this additional agent perhaps is not. If they're able to remain on the steroid-sparing agent and off of prednisone, then kind of spacing the scans out over time. And then if it remains stable at about kind of that 3 to 3.5, 4 year mark, then perhaps repeating a PET scan, making sure that things are metabolically inactive or very low activity, and then if so, potentially reducing the steroid-sparing agent perhaps by 25% every 3 or so months, scan with each time and then see if things are continuing to remain quiet. And then if they are, potentially being able to discontinue therapy, which would be, I think, the goal for patients. But really, we're talking about kind of 4 to 5 years from the diagnosis at this point. So that's kind of conceptually important for patients to understand, because they're always wondering, is this going to be a quick thing or a lifelong thing? And the answer is perhaps somewhere in between, but trying to get off of therapy if possible. A lot of questions come in as far as, will this go away, right? And so if we look again at our 314 patients that I mentioned, a small percent, about 7%, had full resolution, but similarly, a small percent, less than 10, actually worsened by the last follow-up. About a quarter didn't change, and again, some of these are probably because they were more fibrotic than inflammatory at the diagnosis or at the identification, but just less than 2/3 ended up having improvement but not full resolution. If you look at the patients who ended up resolving, and then you end up kind of discontinuing therapy after resolution, only about 10% actually had a recurrence. So it is possible, if there's full resolution, to come off of therapy, and a minority of these patients will recur. But it is reported, and so ongoing monitoring may be required, but often perhaps with more spaced out imaging studies. So again, in this context, I hope that I was able to identify and provide some context of differentiating between primary or idiopathic retroperitoneal fibrosis and secondary causes, which must be considered and excluded when evaluating patients. That's the reason why the right diagnosis should be identified. And really, that's largely because the treatment may end up being impacted by what the cause is. And the outcome is largely based on what is the disease driving it. As a patient, it's important to advocate for yourself. So you feel like if you're not getting answers or don't have an adequate care team, to seek areas that have experience with this. And so on the Retroperitoneal Fibrosis Foundation website, there is an area that we're trying to increase in regards to providers who feel comfortable with this condition. Right now, we have a lot of rheumatologists, but we're trying to include urologists and other providers that feel experienced with this as well. If you or your local care team don't feel like there is benefit that's being identified and you have concerns, I think it is important to consider additional opinions to see if further explanation can be made in regards to your current situation. Unfortunately, since this is an underappreciated disease and it's not really nicely housed within a specific entity, like for instance, rheumatoid arthritis is a strong focus in rheumatology research because that's rheumatology, right? Whereas retroperitoneal fibrosis, people are a little bit hesitant to kind of say it's for sure a rheumatologic condition, again, because there's such a wide array of reasons why these fibrotic conditions can occur. And so we do need better research into these spaces. We're trying to actively do that within our center, and we hope that with time, additional studies can lead to more clarification. This is also one of the main reasons why things like the Retroperitoneal Fibrosis Foundation are helpful in trying to stimulate interest in this, donations to increase awareness, education, and research as well. So with that, I'd be happy to take some time for questions, and I thank you very much for your time and your interest.